My name is Bill Hammond. I'm the Director of Health Policy at the Empire Center. Thank you all for coming this morning. I do have a couple thank yous to make. I want to thank the New York State Health Foundation, David Sandman, for providing support for this project. I want to thank the Empire Center for giving me a platform to do this kind of work. And there are just dozens of people who help me with the research and providing critiques and comments and data, and that was all amazing. And so there's too many of you to name, but I do want to express my gratitude. So I'm here today to talk about the New York's hospital ownership laws and how they affect the performance of New York's hospitals and whether they ought to be changed. New York's hospital, the laws are kind of unusual. I think they kind of fly under the radar for most of us, but most states don't have laws like this. In fact, maybe no other state has laws quite like this. At their core, one of the things basically what they do is they discourage for-profit operation. They restrict it pretty severely. So for example, if you are going to own a share of a hospital, you need to have a background check by the health department. You have to be a natural person. You can't be a pension fund or a bank. And you also, if you're going to sell that share, you may need to get prior approval from the health department. So all of that makes it impossible for a hospital corporation in New York State to have stock on a stock exchange. And so that wipes out an entire model of ownership. There's other models of ownership that are impossible under that regime. And you can still get a small partnership together and buy a hospital, but that model has become very unsustainable. The last hospital to do it that way, Parkway Hospital in Queens, closed in 2008. So for the last 10 years, New York has been one of very few hospitals and certainly the largest, one of the very few states and certainly the largest state that has had absolutely no for-profit hospitals. They're actually pretty common in the rest of the country. Over a quarter of all hospitals are for-profit. And so New York has replaced that segment of our industry with all not-for-profit. So as I set out to do this project, I thought, well, if this policy is working as it should, it would be improving the performance of New York's hospitals. It would be giving us high-quality hospitals because not-for-profits don't have to worry about profit. They can focus on giving the best care to everybody. You would expect them also, because they're not paying taxes and they don't have shareholders to worry about, you might expect them to be more affordable. And I think you'd certainly expect them to do more charity work, to treat a lot of poor patients and a lot of patients without insurance. And so I looked at the data on New York's hospitals versus the data for the other 49 states. And what I found was actually just the opposite, that our hospitals on one benchmark after another are not only below average in terms of performance, but often they're quite near the bottom among the 50 states. So this is the federal government's report card on quality. The average score is last among the 50 states. Consumer Reports does a scoring system. Our average score in Consumer Reports is 47th. Leapfrog puts out a report. We're 48th in their report. But also financially, this is something we hear about during budget season in Albany. The hospitals will come and tell us that they're suffering financially, and indeed, the data bear them out. They have the second worst profit margins in the country. They have a high level of debt. In this case, liabilities to asset ratio is very high. And this one surprised me. I expected that a state that put so much emphasis on not-for-profit hospitals, there would be a lot of uncompensated care. The level of uncompensated care in aggregate is a third lower than the average and ranks 42nd. Some measures that we focus a lot on in trying to improve hospitals. Length of stay is still quite high. It's been coming down, but it's still quite high. 30-day readmission rate, again, that's been coming down, but it's the highest in the country. One area where we're not below average is spending. We're 14th. That's probably mostly due to cost of living issues. However, if you were expecting that we were getting some kind of a discount on hospital care as a result of excluding for-profits, it hasn't worked out that way. And you can see there's a gap between the for-profits and the not-for-profits. And the government-owned hospitals are kind of in the middle. But the gap between New York and the rest of the country is larger. And that the far right bar is the government-owned hospitals. They're kind of bringing down the average. But even if you took the not-for-profits on their own, they would rank 49th in the country. This is digging into the uncompensated care number. The two right-hand bars are the national numbers for not-for-profits and for-profits. They're almost exactly the same. So at the national level, it doesn't matter what type of ownership you are, you're doing about the same level of uncompensated care. But the other thing that stands out to me in this chart is the disparity. At the national level, government-owned hospitals are dealing with uncompensated care at a rate of about 2.6 to 1 with the private hospitals. In New York, it's 6 to 1. So it's the disparity is more than twice as big in New York. What this means is that we're putting a lot of the burden of uncompensated care on New York City's hospitals and other government hospitals, and you're creating a level of economic segregation in the healthcare system, and that probably translates into some ethnic segregation as well. It's a similar story on Medicaid. Our Medicaid system is larger, so that kind of elevates all of the levels. But the disparity, well, first of all, the nonprofits and for-profits at the national level, again, are on a par. They're doing about the same amount of Medicaid. And the disparity in New York between government-owned and the not-for-profits is, again, larger. So all of that data, it paints kind of a grim picture of New York's hospitals. I would not attribute all of that to the fact that we don't have for-profits. I don't think that's stretching a point too far. But I do think it suggests that the strategy of excluding for-profits is not an effective way of improving the performance of hospitals, because it's been in place for decades, and we haven't created ourselves as like a haven of high-performing hospitals. There are other drawbacks beyond performance. Not-for-profit hospitals can't raise capital the way for-profits do. They can't sell stock. As a result, they're more dependent on government funding. They don't pay taxes. I would estimate, in the report, I estimate they're not paying about $2 billion in taxes, about half federal, half state, local. At the local level, that can be a really big deal. In Albany, we have Albany Medical Center and St. Peter's Hospital. Right now they're not on the tax rolls. If they were added to the tax rolls, the city school system up there would see their tax base increase by 19%. So they're two major employers, and by not being on the tax rolls, that makes a big difference in the overall financial picture of local government. Okay, so in return for their tax status, hospitals are expected to provide community benefits. So I looked at the IRS forms for the 20 largest hospitals in the state. Combined, they reported $4 billion in community benefits, 13% of revenue. But the bulk of that was in two categories, Medicaid losses and physician training, also known as graduate medical education. Medicaid losses, I mean, that's a legitimate thing. Medicaid probably doesn't pay hospitals well enough, certainly compared to other payers. But as we saw before, for-profit hospitals are treating Medicaid patients in other states at exactly the same rate as not-for-profit. So it's not a unique benefit that you need a charitable institution to treat Medicaid patients. Physician training, there's some debate about whether that should be counted as a community benefit. Hospitals are subsidized to do it through Medicare. The physicians, as they're being trained, they're providing low-cost labor to the hospitals, and a lot of them end up leaving the state. At any rate, the things that we think of as being charity, especially charity care, you can see is less than 1% for these 20 hospitals. I also looked at the comparative research. It's true that when studies have been done comparing, for-profit to not-for-profit head-to-head, most of the studies that I found saw a performance advantage in the not-for-profit side. Not all. There were some studies that either showed the opposite or saw no big difference. It may be that gap is closing. There's been a lot of those studies go back to the 80s and 90s. There's been a lot of focus on monitoring quality and reporting quality since then. There's money on the table. The reimbursements are starting to be tied to performance scores, and that may be bringing all hospitals up to a better level. Within each ownership type, there's wide variation. You can have a 1 or a 2-star hospital that's not for profit, and you can have a 4 or 5-star hospital that's for profit. And so our policy, by shutting out all for-profit hospitals, shutting out the 4s and 5s along with the 1s and 2s. The most recent study I saw was a study particularly of conversion. It looked at hundreds of hospitals across multiple states over a 9-year period, 1.8 million patient records. What they found was that converting to for-profit status compared to a control group, the hospitals improved their financial standing. They had healthier balance sheets without compromising their quality ratings or their mix of patients. They were still treating the same number of Medicaid patients as they had compared to the control group. Another thing that comes out of the research is that New York is kind of an outlier. I'm sorry for the scatter plot, but this shows the percentage of hospitals that are for profit versus the average score in that state. And it's kind of all over the place, but the trend line shows there is a small negative correlation. If you have a lot of for-profit hospitals, your overall score is likely to be lower, but New York is the exception to that rule, dramatically over on the lower left. So to summarize the pros and cons, if you were to, and I should point out, there have been proposals to change the law. Senator Hannan has been the sponsor of one. The governor included pilot projects in several of his budgets earlier in his administration. None of them came to pass. One bill passed the Senate, but that's about as far as it got. They ran into opposition, especially in the Assembly. If we were to open the door to private investment, you would potentially get an influx of capital. I say potentially because there are some people who think that investors would look at New York State and they wouldn't be interested. They would look at the other conditions, but undoubtedly somebody would come in, and it may be more than we expect. They would pay taxes. For-profit hospitals generally have much stronger operating margins. They have much less debt. They're much less dependent on government subsidies and, I forgot to mention, increasingly in New York, we're not just giving not-for-profit hospitals loans, we're making grants to them for capital. And the state has committed $3.8 billion over just the past 5 years in healthcare capital, a lot of it is going to hospitals. There's not a lot of actually good safeguards on that spending. So that would, in the case of a for-profit hospital, you don't need that kind of financing. You can go right to the capital markets. It would bring in a different group of talent, a different management approach. Some of the larger chains have economies of scale, and they have best practices programs. That would be a good thing. And it might also change. It might also kind of goose the culture. I guess that could be a mixed blessing. On the negative side, I think a lot of people are concerned about the idea of introducing. There's a philosophical objection to having the profit motive in healthcare. The problem with that is the profit motive is all over healthcare. Most of our nursing homes are for-profit. Most doctors in private practice are part of for-profit partnerships. The pharmaceutical industry, pharmacies, it's widespread and it's not even controversial. There's concern that if you have to pay dividends to shareholders, you're going to be diverting dollars out of the healthcare system and maybe even out of the state. But on the other hand, if you're paying taxes, you're pumping money into the state government at least. There might be concern that for-profits would be extra aggressive about grabbing for the most lucrative patients. That is something actually that happens in the not-for-profit sector too. We do have a certificate of need system that can try to manage that. There's a feeling that not-for-profit hospitals would kind of shun the poor and uninsured. Well, it's not borne out by the data. The data show that the for-profits are treating the Medicaid patients at the same rate as the not-for-profits. So looking at all of this information, I come to the conclusion that changing the law, allowing for-profits, the benefits outweigh the negatives. And I think it's especially the case if you think about a struggling hospital, and they've kind of come to the end of their rope in terms of borrowing money, and their choices are close or be taken over by a for-profit company. If it comes down to that, I don't know why the state should stand in the way, especially if it's a company that has a record of running hospitals well. And also, I don't know why they would want to turn down the opportunity to collect taxes also. So that said, in the course of doing this research, I came across the picture that I painted of where our hospitals stand in terms of performance. And I don't think that, even though I think changing ownership laws is a good idea, I don't think it's adequate to the situation. I think I'm hoping that this is the start of a conversation about, how our hospitals are performing, what's going wrong. I think there must be something systemic for us to be an outlier as we are in terms of having an all not-for-profit system and being kind of low on the quality scale. There's something systemic going on. I don't think it's just about ownership laws. And so I think we need to confront that and dig into what's going on and try to fix it. I should say I say all this stuff in an attempt to be constructive. I'm not a doctor, I'm not a healthcare professional. I understand that running a hospital is an enormously complicated and high-stakes job, and I actually think virtually everybody who's involved, the people treating patients, the people managing the hospitals, people regulating the hospitals, people passing laws, they're all trying to do the right thing, but they're in a system that's dysfunctional, and that's what we need to focus on. Thank you all for listening.
Just in the order in which they're seated, I have Senator Hannan next to me, the longtime chair of the Health Committee in our state Senate, Elizabeth Benjamin from the Community Service Society, Bruce Vladeck from Nexera Consulting, and Steve Berger, who has many titles, chair of Odyssey Investment Partners, former chair of the Berger Commission, and other involvements in healthcare. So thanks to all of them for doing this, and thanks to all of you for coming today. We have a simple game plan. I want to spend some time exploring Bill's paper and hearing reactions to it. But just as he said, we are going to broaden the conversation to really talk about the state of New York's hospital industry and how it can be strengthened and move beyond just the question of ownership laws.
I want to take everybody back just for a moment to 1964, 1965, when Nelson Rockefeller appointed Marion Folsom, former, not secretary, but commissioner of health, education, and welfare, to run a commission to look at costs and quality in the state of New York. As he brought the report forward, there was opposition to his recommendations, primarily from Catholic Charities and a fellow who some of us in the room remember, named Cardinal Francis Spellman. That was also the time when St. Francis Hospital was going broke, when the Cardinal was selling his coin collection to protect the hospital, and he was worried about competition for the Catholic hospital system. And the deal and the reason this is an issue in front of us today is because as part of the deal that was worked out in 1965 between Charles Tobin, who represented Catholic Charities, and Saul Corbin, who represented the governor, was the ownership issue. And it was conceived at that point as to protect the Catholic hospital system from predatory investors who would hurt the system. As Bill said, subsequent to that, the theoretical support for this was to keep predatory commercial for-profit people out of the state to protect the community hospital network, and neither Cardinal Spellman nor the other efforts seem to have worked very well if you look at what's happened to the system. And as David knows, when we ran the commission, we talked to the for-profit hospitals, and they were not interested in coming into New York State, as Bill indicated, for two reasons. One is we were way overbedded, we were overcosted, and we were overregulated. That's my history piece.
Thank you. Elizabeth.
Well, I first of all, I want to thank everybody for coming. This is quite an audience and quite a set of co-panelists, so thank you all for including me in this morning's event. And Bill, I think you've done a pretty extraordinary job of pulling together lots of important statistics and data that I think we do, and I agree with your, I think, final call, which is I think we need to really continue to think about how New York provides its hospital care and how we're funding it and how we're structuring it and thinking about it. And we're not there yet. And I think that's clear. I think the thing that sort of struck me about your report was all the data about our private and non-voluntary hospitals sort of seemed to indicate that they were already behaving like for-profit hospitals, and that was, not what we would like to see. The Community Service Society of New York in January put out a report that showed that, for example, one bucket of funding that the federal government gives to New York in $3.6 billion a year, 1.2 billion of that is allocated for a thing called the Indigent Care Pool. And I think many of you know that for the last 20 years, a group of advocates have been extremely distressed about the way that pool has been allocated. It's allocated, unlike in most states where it's allocated basically for your public hospitals. New York State has the Let a Thousand Flowers Bloom approach to allocating, essentially charity care funding. And even though we were able, through lots of negotiation on all sides and lots of give and take from, the hospitals, from government, from everybody, we were able to get about 85% of that accountable in 2012. We still have 15% of that is being allocated in sort of a kind of crazy, kooky way that results in essentially a $318 million windfall for private and voluntary hospitals above what they actually spend on financially, people eligible for financial assistance. Well, why does that matter? That matters because we at the Community Service Society, along with an amazing network of community-based organizations in every county of this state, help patients every single day who are uninsured and need hospital care. And when they apply for financial assistance, are either turned away or rebuffed or, given the runaround over and over and over again. So in our report, we say, we have every year for the last 15 years said, just make one form. Make every hospital, they're getting $1.2 billion. Let them all use the same darn form so patients can, access the system in a fair way. And yet that still seems to be a burden for the hospitals, and enough is enough. Let's, even when the state brought in their auditors, as we showed in our report, the majority of the hospitals, failed many of the questions. And so the auditors, what did they do? They stopped counting the questions. Like, that's not an auditing regime that anybody gets to follow, that's at least audited by the IRS. So that's, very frustrating for us. It's also this caller has resulted in sort of weird windfalls, like Memorial Sloan Kettering. Okay, if I get cancer, maybe I want to go to Memorial Sloan Kettering. I don't, I'm not like trying to pick on MSK. They do amazing cancer work, of course, but they're getting a $35 million windfall every year, which is 500% more than they actually spend on charity care. They have $100 million net operating income just posted this Monday every quarter. Do they really need that $35 million that should be going to true safety net hospitals who are really shorted under this system? So I think we really need to think that through. And then finally, Bill, I think your solution, I'm worried if we're, say we're not just concerned about uninsured patients, which of course is very much my lens, but if we're thinking about really trying to control costs in New York State, the article that I felt like wasn't cited in your report, but is very interesting, is a recent Health Affairs article from 2015 from Bai and Anderson, guys at George Washington and Hopkins, who analyzed the top 50 hospitals who have what's called a charge to care ratio. And they found that 98% of those hospitals were for-profits. And why do we care about that? Well, if you're uninsured, you're going to have to pay the charges. If you're going to a for-profit hospital, you're going to have 1,000% markup rather than the mere 340% markup you might get in a private or voluntary hospital. So, that matters for our guys. I'm concerned that if we do let in for-profit hospitals, it's going to be, it's not clear to me that they're going to do any better job in controlling costs for the people that have to pay full freight. That's uninsured people in workers' comp, whatever. And so I think we really should look at your proposed solution carefully, because it may not be the right recipe for the dinner we want to eat or whatever. I'm not sure. It's not a great metaphor, but thank you very much.
Thank you very much, Bruce.
Thanks, David. I don't really know where to start. In the interest of time, just a few relatively telegraphic points. One is, and as I told Bill earlier, his depiction of the role and size of for-profit hospitals in the United States is, I think, very misleading. It is true that somewhere over 20% of all the hospitals in the United States are under for-profit ownership, but they are disproportionately small. And so on any given day of all the patients in acute hospitals in the United States, the proportion who are in for-profit hospitals is about 15%, which is a number that has been constant for at least the last 30 or 35 years, fluctuating up and down a couple percentage points a year. But second, the suggestion that this is, New York is somehow unique in its absence of for-profit hospitals. There are at least, and Bill's counts and mine differ somewhat, there are at least 4 or 5 states other than New York where there are no for-profit hospitals. There are another 10 states where their market share is below about 5%. if all of New England, pretty much, the northern plains, the Pacific Northwest, the presence of for-profit hospitals is very, very limited. Conversely, if you look at just 5 states, Texas, California, Florida, Arizona, and Nevada, they account for almost 60% of all the for-profit beds in the United States. So the fact is that the for-profit hospital companies have developed a strategy over the years in which they've shed their previous ownership of large urban hospitals with academic components, in which they have focused on saturating rapid, fast-growing markets in the Sun Belt, where most of New York State doesn't qualify on the basis of those demographic or meteorological conditions. The second point, very, very quickly, is this notion about charitable work and charitable contribution and the role of New York's not-for-profit hospitals, because there's a certain circularity in that. New York has, along with a couple of other states, the most generous Medicaid program in the United States, as a result of which, as the chart on, or the table on page 13 of Bill's report itself shows, the average nonprofit hospital in New York provides 50% more Medicaid shares, as a market share of Medicaid patients, 50% larger than the national average for nonprofits. It's not surprising that our uncompensated care number is relatively low in that, because that is largely calculated, the way most hospitals report uncompensated care, as bad debt on uninsured patients, and we have fewer uninsured patients in New York than in most other metropolitan areas. I'm totally in sympathy with Elizabeth's point about the allocation of subsidies for uncompensated care. In fact, I'm not as old as Steve, but I'm old enough to have been part of the process in the early 80s when we provided for the first subsidies for uncompensated care in the New York State's hospital payment system. And I've lived with this issue for a long time. The fact of the matter is, under federal law, there is a limit on the amount of uncompensated care payments under a number of different names we have for them in New York that can be made to any given hospital. And the public hospitals, at least in New York City, are at the cap. There is no way under existing Medicaid law that federal government will match any additional uncompensated care subsidies to the public hospitals in the state. And that's a problem in terms of figuring out how to deal with continuing subsidies, particularly to the publics, but to some of the less affluent nonprofit hospitals in low-income communities in the country. 2 other points really, really quickly, because they both have to do with data and selective choice of data and multiple confusing data. In absolute terms, Bill suggested that the reason New York hospitals appear to be higher cost than those in other countries and in other parts of the country are because of high input costs, costs of doing business in New York State. And that's true, but in fact there is data using the Medicare data, which is the one national health insurance program, to adjust for costs and patient characteristics for inpatient hospital care around the United States. And in the Medicare data, the input cost adjusted costs of hospital care in New York are in the bottom quartile of the United States. They're less than the median cost in the United States. We do have longer lengths of stay than elsewhere in the country. We do have higher readmission rates than the rest of the country. We also have lower 30-day post-admission mortality rates than hospitals serving Medicare beneficiaries elsewhere in the country. And there may be some causal relationship associated with that as well. In general, the whole world of quality measurement at the moment is up in the air, and there is a complicated relationship between the quality of the measurement and the amount of public relations investment that's associated with making visible those measures. The Leapfrog Group is the most extreme example about that. Most of the serious quality measurement communities dismisses their rankings just about out of hand. And CMS itself has acknowledged serious flaws in the star rating system, which, among other things, systematically overrates small to medium-sized non-urban hospitals of the kind that are disproportionately owned by the national for-profit company. So, and there are other measures on which New York looks substantially better. One last point that I hope we'll discuss, and in the course of this, at the very end, Bill talks about in his presentation, I don't recall seeing it in the paper, but that may be my fault, the costs associated with physician training in New York. And I think if we're going to understand the healthcare system in New York, the hospital system in New York, and particularly in comparison to other parts of the country, we have made in this city over many, many years an extraordinarily disproportionately large investment in medical education and the associated research and other activities that are associated with it. It's very expensive. It probably in some ways conduces to more negative patient ratings on a variety of quality measures. Yet in a country that is short of physicians and is going to get a lot shorter of physicians, New York, and as Bill points out correctly, half the physicians we train in this state or more eventually practice out of state. We are providing an enormous subsidy to the healthcare system elsewhere in the country that is not recognized in any of our accounting or payment mechanisms. And that makes it much harder, frankly, to run highly efficient hospitals in New York. And at some point, we're going to have to face more explicitly the extent of this commitment, whether we can continue to want to promote it and can afford it, and then what it means for the operations of a healthcare delivery system and how we're going to appropriately pay for that.
Thank you. So far, Steve is the only person who followed the time limits, but you made so many good points. I appreciate it, and we will come back to many of them. Senator.
How much? 3. The point that I always like to start off with when we go in talking about healthcare and policy is we tend to get into too many details and mazes, and we forget that it's all about how well we treat the patient. Mm-hmm. And if we don't keep coming back to that point, I think we get lost in a lot of the debate. So I obviously sponsored the bill. It's in the paper. I'm not going to get into those stories unless asked because those are interesting. But I do think there's a major conclusion to be taken from this paper, and it's not necessarily for profit. Although, Bill, I think it's great. If you want to get the attention of the healthcare community in New York, you talk about the for-profit. It's better than putting sex in the title, believe me. The
For-profit sex.
Okay, we have to stop right now.
That's another debate, David.
It's not working out.
It's a gender-free discussion.
Back to the paper.
There are a number of standards that are there. Leapfrog has obviously gotten the attention of people, and it will take the greater New York and Haney's and drive them stark raving crazy. But there are some other standards in the paper that are cited, and you have to pay attention to that. And maybe if New York was in the middle of all the states, you could say, oh, there's measurement and all of the very sophisticated factors that Bruce just mentioned. But we're at the bottom, and that's the most disturbing. And what are we delivering for all the money we're doing? And that's why it's patient-centered. And I thank you, Bill, because you've called attention to what we have to do. Now, we have actually tried, out of the wake of having legislation in regard to for-profit. By the way, it was not for-profit shareholders. It was private capital coming in. It was on an experimental basis. I think my bill had 10. The governor's may have had 2 or 3, one of which was Brooklyn. That was a little bit of a indication. But we've major infusion of capital through a program, and it's on page 23 of Bill's report. $3.78 billion the state has authorized now. Now, not all of that is out, and not all of that is for building. A lot of it is for transformation, because that's the crux of the money going out. Many times we have weak hospital systems that, if they go out of business, will simply leave a void in the healthcare delivery. It is the thought that there could be resuscitation to them as healthcare systems if a bigger system took them over. But as long as the weak system has capital needs that would impair the larger system, you can't get them taken over. So part of this infusion is for that. But it's a major thing, because the argument for for-profit capital was, look, they have no other way to go, and we're going to have to do something about capital. And that had been a debate that had been going on, and this Cuomo administration has stepped up to it. One last point I'm going to make. People will say to me, well, I'm coming to New York, I'm going to give a talk at a university. What are the characteristics about New York healthcare? And I go, for-profit versus not-for-profit. It is an absolute philosophical belief that we have to have not-for-profit. I also will say as a footnote, by the way, over half of our nursing homes are for-profit. We have allowed dialysis to come in for-profit. And I do not know of anybody working in a hospital that volunteers. So we'll leave it go with that.
Thank you all. You all made so many great points. I'm going to try to circle back to a lot of them in the discussion. So Bill, let's start with you, because you put so much on the table. You know, questions about quality of care, questions about prices, questions about public benefit. You kind of tackled the whole thing. And Senator, you did me a big favor by saying the North Star is always patient care. So let's stick with that. Bill, you make a lot of good pro arguments for why we should do this. You know, you assert that it would be good for the hospital industry. You obviously say it would generate a great deal of revenue for this state. But I didn't really see the affirmative argument for why this would be good for patients. So if there is one in your mind, could you speak to that?
Well, the primary benefits, if you're just talking about the difference between ownership models, the primary differences are financial. They're, they have different access to capital, they have stronger bottom lines, they pay taxes. So I would acknowledge that the argument, the affirmative argument for allowing for-profit hospitals in is not primarily about quality. There are probably some spin-off effects. I mean, if your hospital's losing money, that's probably going to hurt performance in some way. If you're not losing money, maybe you're in a better position to do some quality improvement efforts. I talked a lot about quality in the report because of what I thought it said about the status quo. I think what we need is a better approach to regulating quality that would be sort of agnostic about ownership. Like, I think what we're doing now is we're kind of relying on the mission of not-for-profit organizations to be one of our primary quality enforcers. Like we're because these are not-for-profit organizations, we're trusting them to do the right thing, and by and large they're trying to do the right thing. But I think there needs to be a healthier tension between the regulator and the regulated. And again, I don't, switching ownership models isn't necessarily gonna change that. But as long as we're, I'm concerned about quality. I would not present this response as a fix for quality. I think it's a financial fix. Quality is something we need to address elsewhere.
All right, so let's dig in on quality then, because, Bruce, you took some exception to the data that was cited and said at best it was selective. You offered up some other things that would put New York in a better light. Senator Hannan, you said, you can take issue with anything, but the overall pattern ain't good for New York. So let's explore that, and I'll throw that question to anyone who wants to take it.
Well, let me just say that given our current quality measurement methods, a large multi-specialty hospital serving a lot of very sick people, including a large proportion by national standards of people of color, is, all other things equal, going to get a lower score on our quality measures than a small community hospital in an ethnically homogeneous community with a much narrower range of services. And that's, I think, now consistent conclusion in the literature about quality measurement issues. It raises the question of who the appropriate peer groups are for looking at New York's hospitals, and how we do compared to them. And I think that would be a very fruitful place for more research. I don't know, I'm not familiar with a whole lot of research in that regard. I suspect we'd probably not be last, but we wouldn't be on the top either. And I can think of some inner city academic medical centers with which I'm familiar, which I think do an outstanding job compared to a pretty good job at their peers, to the extent it's comparable in the city. So, but there's a lot of apples to oranges comparisons in our quality measures, and the other component of that is because a lot of the CMS ratings, for example, are tied to patient evaluations of their care using an obsolete measure for which I'm at least partially responsible, so I feel very guilty for it. But all other things being equal, patients who are treated by house staff are going to give you less positive responses than patients who are treated by a physician with whom they have an established relationship. So I think I think that's why we really have to reckon not just in terms of expense and narrow issues of professional supply, with more broadly the impact of our overwhelming engagement in teaching in the New York hospital system as it ripples through in terms of all its effects on care in the community.
Can I ask you or anyone, it's a very practical question, right? So there are literally thousands upon thousands of healthcare quality measures out there. People use the phrase measurement madness all the time. And on the one hand, I agree with you that the art of quality measurement is woefully underdeveloped. But every hospital executive I know says the biggest problem is this multitude of measures. If we could just standardize, and agree on some uniform set, we'll do it. But having to respond to a gazillion different measurement systems is terrible.
Well, I think that's true. There's another point, though, which is there is this mania in this country for rankings and scorecards, which tends to drive us towards summative measures like the star ratings in CMS, to say this hospital's a 4 and this hospital's a 2. And in my experience, if you look particularly again at hospitals that are full-service, multi-specialty, there is probably no hospital in the United States that is in the top 10th, top percentile in all services. that even, if you look at even something as phony as the U.S. News and World Report rankings, not, even the top 10 hospitals aren't in the top 10 in all services. And it's a complicated issue. Some very good hospitals do better on some things than others. These are big, complicated institutions. And the notion, and quality itself is multidimensional, the notion that you could rank them on a single summative measure is, I think, very misleading. We know that there is more inequality. We know that there's more, the technical term, there is more intra-institutional variation than there is interinstitutional variation. If you look at some of the easy things to measure in quality, like cardiac surgery, where New York State pioneered measurement and has been doing it for a while, we tend to do very well. But partially because we've discouraged hospitals that don't do well from staying in the business. But the hospitals that are best in cardiac surgery may or may not be the best in cancer care.
There's more to say, but we have a lot of ground to cover. So let me move on to something else that Bill raised. Bill's paper says that New York's nonprofits provide less free care than hospitals nationally, regardless of ownership status. And I know, Elizabeth, you and I had a side conversation actually a few days ago, and you were like, I don't think just saying you take care of Medicaid patients is really an adequate sign of public benefit. So I'd love to hear your thoughts on that part of the paper.
Yeah, I mean, I think that's, I couldn't, I mean, yes, that's what I think. I think, in New York State, and in many ways, thanks to the hospital system, we do have a robust Medicaid program. We do have a generous Medicaid program, and I think all the stakeholders in this system, including the hospitals, have worked really hard to have a robust Medicaid program, and we should all be lauded for that. I think in New York State we've also figured out how to compensate the hospitals quite well for accepting Medicaid patients, and in fact Health and Hospitals is complaining, sometimes, as part of the Blue Ribbon panel, I think we were concerned that some of the Medicaid patients were going to the private and voluntary hospitals. I wanted to kind of pick a bone with Bruce, though, on this last comment, which is, the reason, I can't believe, maybe I didn't hear you well, but the reason why New York does poorly, one of the reasons why New York does poorly on quality indicators is because of the racial mix of the population. And I just want to point out that, first of all, that the public hospitals on average take 10% more people of color, African American populations, than the private and voluntary hospitals, or 5 or 6%. And also, what I think, if we're saying that one of the reasons why we do poorly on quality measures is because of health equity and health disparities, then we should do what CSS has been calling on for well over a decade, New York to do, which is actually incentivize our reimbursement structure, which drives most behaviors in the healthcare system, to reward those hospitals and payers and providers that help address health disparities. And we've never really taken on that effort, which is something I think we should definitely do, especially since we're the fourth largest, as a state, we have the fourth largest number of immigrants and other people of color. And so I think we should definitely take that challenge and actually do something about it, and not use it as an excuse for our poor performance, which I'm sorry if I'm being a little too harsh on that. But I really take umbrage with that. And so I just
I don't always take umbrage. I think, again, the fact of the matter is that the data is pretty clear that many of our quality measures have a disproportionately negative effect on hospitals that serve a very large proportion of people of color. I mean, that's very well established. And it's one of the reasons that health and hospitals always perform so poorly on quality measures, is because of the characteristics of the people they do, which, again, to me is a comment about the quality measures. On the payment issues, I have to tell you, I couldn't agree with you more. I've been yelling at, well, I've stopped yelling at CMS because there's nobody there to talk to the last year and a half, but I was yelling at CMS for years that if they're really serious about quality improvement. Instead of penalizing hospitals with high readmission rates, they would look at the characteristics of their patients and pay more for hospitals that had a higher proportion of patients at high risk for readmission. And the quality community goes bananas when you suggest
Right.
that.
So this is a very fierce debate, right? There are many who would say, and if you look at the data across the country, it is true. If it's not adjusted for SCS, those who serve disproportionately lower income people, et cetera, do get penalized more. Truth. CMS's response, at least when they were there, was number one, we are not going to agree to different standards of care based on income. Everybody is entitled to the exact same standard of care. And it doesn't have to be that way, because there are plenty of safety net hospitals who do perfectly fine, despite the overall pattern. So it's a fierce debate. There's good arguments on both sides. So I'd love to hear thoughts on
Elizabeth's
that.
right.
When can we go on the dish cap? I want to figure about that too.
Steve?
I guess I would make a couple points. I understand how fraught and difficult and even dangerous the rating process can be. If you do it wrong, you can actually punish the good performing hospitals. I think we've known that for quite a while. I think the measures are, gradually getting better as we learn how to do it. But I think the methodology that I used, I will admit it's kind of awkward, but I'm taking an average. So you're not focusing just on the large academic medical centers. You're not focusing on the small community hospitals. You're combining them all together. And so the flaws that might, say, favor a small community hospital and penalize a large academic medical center, to some extent get smoothed out when you look at it on the average level, because New York has a mix of both kinds of hospitals. Regarding the question of how SES means socioeconomic standing, I had to learn that for this paper, or status. Regarding the interplay between socioeconomic status and quality is definitely there. The thing is that I think what I saw in the data is that New York has a more segregated system. Yeah. And that, like, if you are pushing more and more of your lower income people into the government-run system, that's going to strain the government-run system in a way that's not going to be good for quality. Mm-hmm. Now, the government-run system exists to serve the uninsured, but I'm not sure that, that basic approach should probably be up for question. That we have one set of hospitals that's for the poor and another set of hospitals that's for everybody else. I don't think that may be actually contributing to quality issues. If segregation itself may be driving that.
All right. I want to ask a few more questions that kind of put a period on the ownership thing, and we're going to go back to broader. So Senator, you were the sponsor of the bill in 2015 to authorize a demonstration. So would love to hear your thinking then, and if it's the same today or has changed.
For the moment, it's changed. First of all, it's very hard to get heard when people have philosophical beliefs and you're trying to get into facts. So that's a problem. I think it will come back in spades as we go forward. Going forward, I see my counterpart here in the Senate, Senator Kruger, who's Democratic chair of the Senate Finance Committee, so welcome. You're undergoing further pain than you usually do. I don't see the revenue streams continuing for healthcare and hospitals in New York the way they have in the past few years. When I think of what's been going on, first of all, we have we are now at a point where there are fewer uninsured in New York than there have ever been in history. When most of the debates I would have with Ms. Benjamin would always be about what are we doing on the uninsured rate. Well, and for the moment, that's cured. By the way, she'll want to talk about, well, we have the dish payments from the federal government that are going down. Well, they were going down because we were supposed to have less uninsured. No one's linked those back again, and we have to. And that's a change, that's 600 million that will come in spades in 2020 or 2021. We're facing a Congress that's not happy with New York. So what happens to the outlier? We're an outlier in getting DISH. We're an outlier in getting GME. We're an outlier in a number of other things. They've shown an inclination to start trimming in any number of ways with Medicaid. So I think the debate as to where we get sources of funding is going to come back very sharply. When I mentioned dialysis, that only came about because the system that was there wasn't working too well, it wasn't funded, and this quality was really not existent. So that convinced people to change. Will that come back again? I don't know. But what we're now doing is not necessarily secure. One of the other things, Elizabeth points out that 15% of the charity care payment formula hasn't been addressed. Well, that does mean we've addressed 85%.
That's right.
That's a lot. But you don't see something that the administration has invented, which is called the VAP, VAPAP, VAP, then the VBP dash QUIP. This is, well, this is an incredible system. It's not statutory. It required the acquiescence and practically a request for indemnification from the health insurance companies, and it's driving billions of dollars in this state to hospitals. And we're not just talking, although like Brookdale will get 140 million, but there's things as obscure as A.O. Fox Memorial Hospital getting $1 million. So there's a lot of money that's going into hospitals that you don't see. Already their revenue is 55% Medicare and Medicaid on the average. And what happens as we get over the horizon? And that will bring the debate back.
So Steve, let's say the senator's right, it's coming back,
Yeah.
Imagine that we do, on a limited or not limited basis, allow private equity or for-profit, whatever you want to call it. Are we going to have any takers?
Well, no, not right now. Not right now. And to some extent, the more I listen to this discussion, and while I think Bill has triggered a discussion about hospitals, I don't think that's a central issue. I think the value of bringing for-profits in will be to create capital flow, which we're going to need desperately because the state's not going to be able to continue to support the system. Whether it works, whether anybody comes in, I think is something we will only find out over time. But as I'm listening to the debate, I'm trying to figure out, there's a level which I don't know how to address. But some of the stuff is sort of, running hospitals, Bruce, is very tough. And if we didn't know it before, working through the DSHRP program right now and trying to get hospitals to change their behavior and work in other ways is almost impossible. There are places it's being done, but these are tough institutions with long histories, siloed delivery systems, management techniques, which maybe would have been fine about 1746 when I was born. Stuff like, but they're very hard to change. Why do we have so many poor people going to the Health and Hospital Corporation? Because poor people in the city know they'll be welcome there. All right? You go back to the issue of customers. They know they'll be welcome there, so they go there. Because poor people does not mean they're stupid people. They go where they're going to be taken care of. So that's partly why they do it. And I'm worried about the revenue streams. But and one last piece before I really jump the ship is that when we look at the history of the community responsibilities on the part of the hospitals, however you break it out, it has basically been Zippo. When we tried to link the DSHRP programs with the existing community performance by the hospitals, there was nothing to link it to, by and large. And breaking down the barriers between the hospital and the community still remains something we haven't done, which leads me to why I think I'm nervous about this discussion for one reason, that I don't want to get back into a world where we're confusing hospitals with healthcare. Hospitals are a part of healthcare, and we have not found a way of breaking and reconfiguring, at least in our minds, how we're going to think about the delivery of care over the next 15 to 20 years. David had written a paper, recently, or a Huffington Post. Do you write that stuff or you just bark it? I don't know. Anyway, but if you think about it, we are where we are because of 100 years of history, or at least post-World War II, of funding hospitals, of supporting them across the country, of then supporting workforce activities inside those hospitals, building these hospitals, and convincing everybody in the public that that's what the healthcare system is. And so we're building from the inside out instead of from the outside in. And a lot of this stuff we can't deal with until we figure out which we're figuring out in a couple of places in this state now through DSRIP, not many, but I think there are 5 or 6, how you begin to shift the center to healthcare delivery and to social determinants, right, which is an easy 2 words, which everybody can throw around in every meeting that everybody goes to. But how we actually change it so that we have less dependence on acute care systems. And by the way, we're supporting them today. And Senator Hannan, I know he's talked about, we are supporting a large number of not necessary brick and mortar, which we can't easily just deal with because we also have created an important workforce, particularly in minority communities, that's tied into this. And if you don't think the workforce issue and the political issue and the delivery of care issue are tied together, you look at a couple of hospitals that had 45% occupancy, and you know that that's not the way to build the system. How we turn this debate inside out so it becomes a positive debate, which we can now have for the next 10 years, it's going to take that long to change it. I don't know how to do it because we get locked into where our costs are, and they're in the acute care
It's like
system.
you think we need a commission or something like that.
But it's the one place I know we need a much younger bunch of people to do it.
So, I mean, one fact that I know we can agree on is, New York's hospitals are in very perilous financial condition, and it's not news. It's a chronic condition. I'm so proud of New York in so many ways, but this is a dubious distinction that forever it seems like our hospitals' operating margins rank 50th, 49th, 48th, in the country year after year. Why is that the case? Why are we perennially at the bottom of the barrel fiscally?
Bruce?
I don't fully understand it, but it's true. I mean, I've been involved in this stuff since Steve Berger was middle-aged, and it's always been true. In 1978, when the Council on Healthcare Financing was constituted in the state, we were looking at the lowest in the country operating margins in New York hospitals. I do think it has something to do with the extent which even then, compared to their counterparts elsewhere in the country, with New York hospitals being more highly dependent on public revenues in terms of their total income. And because whatever one can say, positively or negatively about them, the public payers are much more careful about what they pay for hospital and other healthcare services than the private insurers have ever been. And they're tougher customers. And so that may explain some of it. The rest of it, I'm not sure I fully understand, except that in an ironic kind of way, in part because of our strong certificate of need laws, we have I think, but underlying which is the politics, we have retarded the natural evolution of the hospital industry in the sense of the very dramatic reductions in inpatient utilization that have occurred. Every hospital closing in New York, every hospital closing everywhere is a tragedy, but we have shrunk our capacity more slowly than in other parts of the country, and have converted that capacity to outpatient more slowly in other parts of the country, and that's an implicit effect of a variety of public policy decisions as well. But it also makes the financial condition of the surviving hospitals. We have a lot of hospitals that are on I mean, again, as long as I've been in this business, which is a long time now, Interfaith, starting back when it was Brooklyn Jewish, has been teetering on the edge of, or in bankruptcy, and we've kept it alive. But if you look at total financial performance of New York hospitals, it's always been dragging it down, and we've kept it on life support. We have not, until the last couple of years, come up with a strategy to effectively try to effectively replace it with a functional, financially healthier alternative. And in most of the rest of the country, it would have disappeared 30 years ago and would have come off the books as an underperforming hospital.
Yeah, so, I mean, exactly, and you can all weigh in on this. I mean, we actually have 26 hospitals, I think, in this instant that are officially on the state's watch list. Being on the watch list means basically they could not remain open without state financial subsidies. And there's
Also less than 15 days of cash.
Less than, it is very shaky to say the least. And there's probably at least another dozen who are, right behind and could be on that list, shortly. So it's a lot, The first question, should all of those 26 plus hospitals remain open?
Talking about life support, you talked about interfaith. I'm looking at this VAP, VIP, QUIP program, which is a big deal. Brookdale this year, 140 million. Interfaith, 55 million. Kingsbrook, 55 million. Jamaica, 36 million. Now, the collective, St. John's Episcopal out in Queens, 34 million. That's extra, over and above anything else that's going into them. So they're not going to stay there unless we subsidize them. Are they doing good health care? In some cases, totally essential health care. Part of the Brooklyn One experiment is to say, what do we do to change that dynamic? Because the three, Brookdale, Interfaith, and Kingsbrook, have always been on the watch list. Wyckoff, by the way, which is not part of the Brooklyn One, they're getting 70 million. And that's supposedly a community that's changing and gentrifying and all of that. I'm not decrying it. It came through the budget I negotiated. But it is symptomatic of what we're doing to keep it there. You talk about the change in outpatient. We have reduced by about 30-40% the amount of procedures that are going on inpatient. So we're moving to outpatient. So there's a whole dynamic that's going on in the healthcare system that if we start to just do the analysis we're talking about, we're fighting the last war, not the future one. And doctors' practices, totally changing in front of our eyes. I mean, hospitals are buying them up. Healthcare insurance companies are buying them up. They're amalgamating themselves into major practices of 1,000 people together. So the delivery system that we're talking about poor performance, if we start to redo the way we do the quality measures, we have to recognize that there's a different animal out there than there was when these quality measures were developed. So it's a great dynamic, and most of the pressure, by the way, is us, those of us who have gray hair, because we're the baby boomers and we're causing the pressure because we're using the system more. It's not as if all of a sudden there's bad health care going on. In fact, we have some good health care, but we have to figure out how do you measure it and then put proper incentives to improve it.
Can I just make one quick?
Everybody wants to
addendum
comment, so you and
to Ken's
everybody get in
comment?
on this.
No, because if you look at the watch list of hospitals, just to give a better perspective on it, I think, although it's not in terms of dollars or beds, but in terms of the number of institutions that are in that parlous state, the majority of them, if I'm not mistaken, are upstate. And we focus on the problems of a community like Brooklyn, of course, because Brooklyn is the center of the universe. But in fact, there are whole counties in upstate New York which have relatively small hospitals being kept alive by state subsidies, where the hospital is not only these days the primary source of all kinds of medical care, but a major employer as well. So this is, it's a very different characteristics of the community, but it's the same generic problem of what we're going to do with this capacity.
Bruce, rest of the state under this program was 16 million. The metropolitan area was close to 450 million. So it may be the
But
numbers.
per capita, I think it's about equivalent.
No.
Well, but we got to be careful. We the biggest numbers are downstate for a whole variety of reasons. The problem, Bruce hit the problem on the head, I think it was a few minutes ago, which is the transition from yesterday's brick and mortar, large institutional acute care facilities as the center of the healthcare system to a decentralized, distributed system is happening at a tenth or some small percentage of the speed it should happen in the state of New York. It's happening. It's not happening necessarily that fast everywhere, but it's happening faster almost everywhere else, and that may be why the for-profit motive would help. But it's happening. But it's happening so slowly, partly because of the workforce issue and the problems that creates. And you can't just, us healthcare guys can't just brush that off, because it's a center of political life in this state. But if you look at if you step back and say, all these urgent care centers that are popping up, and true, they're popping up, Elizabeth, in more middle-class areas, I understand that. But, and now linkages between urgent care centers and CVS, and and vertical integration, horizontal integration. These are visuals, sort of growths that tell us that the existing system isn't working well. And the ability for some of these new creations to link into the older creations and accelerate the change is one of the few hopeful signs we have. But you can't keep going with with what is, by the way, it's more than 20. So you don't count SUNY hospitals in that, obviously, and we're not counting a whole bunch of HHC hospitals. We're not counting a lot of other people who are really in bankruptcy, and a lot of them are just too big and don't belong there. And the kind of health care you need in the community is much simpler, more direct, outpatient, freestanding than what we now have. And we don't make that transition 3 or 4 years from now. Senator Hannon's numbers on that page will have zeros after them, and there won't be a page because nobody's going to fund it.
Bill, I know you had your hand up.
Going back to your original question, I would just say, you said, should all of those hospitals stay open? I think the answer is obviously not. I mean, it's a really hard question, which one should close. I'm from upstate. When a hospital closes upstate, you're talking about the difference between being half an hour away and being an hour and a half away from a hospital, or 2 hours away. When a hospital closes down here, you're talking about, 3 stops on the subway or something.
No,
4 stops?
No,
Assuming the
it can
subway
be
is
an hour, it
running.
can be the same amount of travel time. It's the same amount of travel time, Bill.
Not if it's the L train.
Yeah,
okay.
it's just, no.
I withdraw that comment.
Thank you for withdrawing.
All right, strike from the record.
But
Keep
I
going.
would point out that the issue is not just that we're these things, keeping them alive is expensive, but you're also keeping alive a dysfunctional institution, and that has, you're, not only are you wasting, you're spending a lot of money that you could be spending elsewhere, you're spending it on low-quality care, by and large. These struggling institutions are not gonna be your 4s and 5s. And that, I mean, in a nutshell, that it's like political paralysis, that we're not grappling with, unhealthy institutions that we're keeping them alive with artificial injections of money, and we're kind of turning a blind eye to how poorly they are or not, they're treating patients. We talked earlier about the $3.8 billion, the capital money. I looked at one episode of that, $1.6 billion, and I compared it to the list of struggling hospitals. So this is the state putting up capital money and saying it's such a priority that we spend on transforming the healthcare system that we're going to borrow money and we're just going to grant it to healthcare providers. Only about a quarter of the money went to hospitals that were on that watch list. At the same time, a grant went to New York Presbyterian, which is on nobody's watch list of financially troubled hospitals. It's running a healthy profit. It can easily afford to borrow money for capital projects. At the same time, a grant went to a multi-specialty medical practice in Westchester County, which was building a medical office building. The pretext of we need to help struggling institutions ends up creating a program, and then that program ends up getting diverted to all manner of projects that aren't related to improving the healthcare system.
So you used the phrase political paralysis, and Senator, I think he meant Albany, I'm pretty sure.
Well, the city too.
But you also sat here and you're like, this can't go on forever. I can't keep voting for these budgets and these subsidies forever. So what do you think needs to change?
That you're going to have to just get down to some basics that are not there. Right now, the last artificial prop that we have is the DSRIP system. And that is putting $8 billion into healthcare. Primarily, it's going into hospitals. So once again, we have done the big picture, and its ostensible purpose was to reduce the number of admissions to hospitals. Not readmissions, but admissions. And actually, in some of the areas where it's operating, people say we have gotten to reducing it by 20% or 22%. But that's a lot of money, and we're 2 years from its ending. Do you think the Trump administration is going to give us another $8 billion, or even half of that, $4 billion? I don't know. So what we need to do is to try to get back to all of the basics that we've said. And if a hospital only has 45% occupancy, what do they need there? Do they need inpatient procedures? Do they need a major clinic there? There is still healthcare needs of a population that's not served. So what much of the Brooklyn One project is to say, what can we do to go back to essentials and have that done? Steve says the social determinant is often mentioned, but there is a pretty decent argument for components for putting that in so that people just don't go back into a society that's not going to take care of their health needs. So I think that can happen. But the last time we made changes, we said the totally regulated system that was NIFRM has to be changed and we will deregulate. Well, that worked for a while. And but then the power struggle between hospitals and insurance companies changed. So we've now become quasi-monopolistic again, and health insurance companies can't ignore many hospitals. Hospitals know they can't be ignored, so and both have access to the media, and so we have this fight that's going on. And I think we're going to have to go back and look at what the HCRA system looks like, how much we're actually taxing companies in New York through HCRA, who's getting all that money. It's not just the the money that Elizabeth speaks of, and look at that as a better system. And the trouble was, Bill fell right in the trap of you close hospitals. Well, what is the major effect of the last time someone tried to close a hospital overtly? We got a new mayor out of it. Oh, by the way, I think the hospital closed anyway. But the symbolism of it is major in New York. Although I must note that since 2000, we've had 45 hospitals in New York close. So Steve Berger worked.
Okay.
Can I try one quick piece?
Sure.
Because, as for not closing a
I
hospital.
have to make one joke, though, because your age has been such an issue, and, even I was around when we had Knife Firm.
Right.
It's odd that,
Right.
like, there is this misty-eyed nostalgia for a system which everybody had come to hate, and it's like, maybe we should go back there.
Well, but partly because things aren't working well. There's almost no community hospital in the state of New York that can survive on the rates they're now getting. We just have to understand that. That is a real issue. And so that's a question we have to look at. And my instinct has been, and I'm closer to Bill on, the ones supporting hospitals that we should not be keeping going as full-scale hospitals is a mistake, because it doesn't allow us to face the reality that some of the hospitals on that list, as hospitals, not as outpatient clinics, ought to be kept as hospitals, but we're going to have to subsidize them at a higher rate. That's one thing but we have to make those choices, which we are not ready to make. The second point I want to make, because we brushed off, and Bruce did a great job brushing off our cost issue. I mean, that was really the whisk broom on that one, boy. The fact of the matter is that there are some costs that are very much out of line. If you look at, for example, not the basic payments in terms of salaries and wages, but if you look at fringe benefits, the fringe benefits levels in New York State in the healthcare industry are substantially different than the rest of the country. The average fringe benefit rates around the country, and I'm not talking about somewhere in the bayous of Mississippi either, are about 35-36%. It's over 60% in the city of New York with the major unions. If we were halfway between those two numbers, we right now would not probably have one bankrupt hospital in Brooklyn. That's a lot of money, Bruce, and that is a big difference in our cost structure.
Let me talk about that very, very quickly, and just make sort of a few points about that. The costs that you're referring to are high relative to other places, because the level of benefits in New York constitute a high proportion add-on to the salaries of the people who are getting those benefits. If you look at, for example, the 1199 health plan, its cost per member compares quite favorably to what's available on the exchange or what's available in the employment market in New York. But as a percentage of the compensation of the workers, it's higher, because in this market, as in most others, lower paid workers tend to get crappy health insurance to the extent they get fringe benefits. The other piece of that, in terms of our problem, is that, in fact, as a percent of total hospital compensation expenses, the unionized members are the expenditures on unionized members is shrinking, as that workforce has been stable or shrinking, while the non-union, highly professional workforce of hospitals has increased very dramatically. The third thing is, again, this is a political issue. Back in the Rockefeller administration, the political leadership of this state made the calculation that they could use federal dollars to provide a vehicle for upward mobility for first and second generation people of color, primarily in this metropolitan area. And they made a conscious decision to pass through labor agreements, to encourage unionization of the workforce in New York, and so on and so forth. And it has worked. And so as we talk about what are we going to do about the increasing inequality in wages and income among New Yorkers, what are we going to talk about as we talk about avenues for upward mobility in New York? This is one of the things that has worked best. And to say, okay, well, it worked in the past, but we can no longer afford it, seems to me to be a mistake.
I'm not saying, well, I started talking about workforce today. First of all, I know the political issue. It's a real issue.
I'm saying it's
But
a socioeconomic issue.
Yeah, but it's
too.
it also saddles the healthcare system with a series of costs which are disproportionate to what we should be spending. And if we're doing this, which is fine, if the public policy is going to be that this is how we create what is at least partially, not totally, sort of the sheltered workshop approach, and it's important for sustaining the nature.
That really bothers me. Those people
know.
work really hard at really crappy jobs, and to talk about it as a sheltered workshop, hospital vice presidents maybe fit that category.
Or presidents.
But housekeeping staff in hospitals don't.
We have numbers that are excessive in terms of the needs of the system.
All right, time out, fellas. We have a very patient audience who I want to get in on this, so I am going to ask you, put one more thing on the table, and then it's everybody else's turn. All right? Bill, you wrote an op-ed in the Daily News this week. Congratulations on that. And the subtitle said, New York's hospitals could use an injection of competition. But the true background, of course, is actually we see a wave of consolidation in the hospital industry. It's true everywhere. It's true nationally, statewide, especially here in the city where we've evolved to a handful of large systems. And consolidation is a very complex phenomenon. It's vastly too simplistic to say it's simply good or bad. But that's the reality, right? I think we're going to actually see less competition in this city and state going forward. What do you think are the implications of that?
I'm going to get a little over my head here because I'm not I'm not a business investor type person. But if you look at the consolidation that's going on in the hospital industry, it's amalgamations, regional amalgamations of hospitals. So Long Island, a lot of Long Island is now under, what are they called? Northwell. And there's similar things happening in Westchester and elsewhere, where a kind of anchor hospital will affiliate with surrounding institutions. So if you live in that area, you have less and less choice about where you go. There's another, it actually occurred to me, I didn't put it in the paper because it was a little speculative, but it occurred to me that if you're part of a national chain, you can move into an area that has one of those regional affiliations. And because you have the affiliation with a national chain, that puts you in a position to compete with a regional monopoly. In other words, you instead of pooling your resources regionally, you're pooling it with a larger corporation. That you get the same economies of scale. They can buy supplies and negotiate deals as a large corporation, even though you're only one standalone institution in a particular area of New York. But I didn't write that subheadline. But no, I actually thought this might open a door to a solution to the consolidation issue.
Elizabeth, you were talking quietly. Did you want to get in on this?
Yeah, I think the data shows that when you have health industry consolidations, prices go up. And that's, I think the last time Steve and I were, was it the Yale Club? Or I think it was, here. We were on a panel talking about Burger 10 years later. And, that's what one of the big takeaways from my perspective of that panel is, I think we should be worried about vertical integration where carriers are owning pharmacies, who are owning practices, who are, owning doctors, who are owning nurses, whatever, I think, who are owning the pricing of drugs, it just, from the consumer perspective, it just means we're all going to be paying more and more and more for health care, and I think it's a deep concern.
I mean, it's a very tough issue, right? Because in some ways, the state who would like to get some of these places off of financial life support from the state has encouraged this kind of consolidation as one possible solution, right? Get a stronger place to take over a weaker place and get them off of the state subsidy, right, Senator?
As a matter of fact, you look at what we had before Governor Cuomo became governor, and we used to have the TV wars when we would have the budget. So that the union and the greater New York would gather together and advertise and say that Governor Pataki or Governor Spitzer or Governor Patterson was going to cause the end of the world unless there was sufficient money that would go into hospitals. And by the way, they would affect each of those governors' standings in the polls. And when I told Governor Spitzer, this is what's going to happen to you, he said, oh, no, impossible. Bingo. 2 months later, his standings had dipped. So Governor Cuomo said, we're not going to do it. So he has tried to, in a sense, avoid that, go into reforming Medicaid, the MRT system, which really in some ways is just shuffling a lot of shells in terms of the Medicaid money. And we're now 1/3 of the state is on Medicaid. So you can lessen it. And the only thing that's going to happen is at some point consolidation has to end, because there's only so many doctor practices you can buy. There's only so many places you can merge. And then we're going to go really start to look at what we can do for community health and population health, both of which are different concepts, but go forward with that. And just because someone is not for profit doesn't mean they're not merging. That's happening, but it's also national. There is a system, a Catholic system called Trinity. They've now bought the St. Peter's system in Albany and the St. Joseph's system in Syracuse, and I don't know who else. But they're doing it for the consolidation and the purchasing power and all that. So it's going on, and at some point, I kid my friend Gottfried, who I have a lot of conversations with about. I said, "You'll have your single payer; they'll all merge together."
All right, it is the audience's turn. I'm just going to ask lots of hands. So I'm going to ask everybody. There's a mic that's going to roam around. Please tell us who you are, where you're from, and please ask a short question, not a long statement, so we can get everybody in the time that we have remaining. So the gentleman right there. And then I'll come to you and next.
DJ Jaffe, Mental Illness Policy Org. Can you tell me what the effect of expanding or implementing for-profit hospitals in New York City or New York State will be on the mentally ill? The state government's getting out, closing their hospitals, the state psych hospitals. The nonprofits are closing, Beth Israel, St. Vincent's, Cabrini Green. There's a plan to close Allen Hospital, every hospital my own relative's been in. 90% of all discharges are city hospitals, so how will this affect the mentally ill if we did this?
We'd have to implement the obligation to treat physically and mentally illness on a par. People are beginning, actually, use of the word social determinant starts to rope in that we have to widen the horizon of how we're treating it. We're not doing it well now, and we certainly, the cutbacks in especially sites for acute psychotic episodes is not sufficient at all wherever you are, Eastern Long Island, Western Buffalo.
But if your bill then required
I don't have the bill I have. The bill I have was situational. This is not some crusade I'm carrying on. I try to be a pragmatic approach to dealing with the situation in the given fiscal year and moving forward. But in terms of mental illness, whether it's mild or whether it's severe, whether it's developmentally disabled, we have a long way to go, and it's probably getting far worse because we have a whole population of people we called kids who are now 21 and 22. Our benefits pretty much end, and yet we have a growing population and growing needs, and we probably have really, if you think about it, an obligation to come up with a program for that.
Thank you, sir. You were next, and I'm going to try to work around everybody.
Hi, my name is Dennis Duffy. I'm retired. I guess you'd classify me as a consumer of medical care at my age and the taxpayer. I think what we heard here is that there's a lot of change going on, but it's not going on fast enough. And we heard that 40 years ago, basically the Cardinal said, I want you guys to ban for-profits because I want less competition. I don't think I can stand up to the competition. But we all know that competition breeds change, lower costs in many cases, and better services. So it seems to me that you don't really need all the Bill's statistics, that this was some kind of a political deal that was made, and it should be undone. We should have competition. The second thing, and this is a question, does anybody know why the federal government set up this system of allocating lumps of indigent funds to different institutions rather than simply have a fund that if I'm indigent and I go to institution A or institution B, it doesn't matter because they can collect from that fund.
We're going to give that to our
care.
former federal official, Bruce.
Wouldn't it be nice
Well,
if the money followed the
mean,
patient?
I like your proposal because that means universal coverage. I mean, at least for hospital-based services, which is the wrong insurance package. But if a hospital gets subsidized at some appropriate rate for every uninsured patient it has, then you've insured everybody for hospital care, which I think would be wonderful and a lot simpler than the ACA. But since we've, as a matter of political choice, decided not to do that, in fact, the way in which we use Medicaid and Medicare dollars, well, Medicaid dollars to subsidize hospitals for care of the poor really came about when, from the argument that hospitals that serve large numbers of Medicaid patients, because of economic segregation in every part of the United States, also tend to serve disproportionately large number of uninsured patients, so that even if you covered their costs for caring for Medicaid patients, they couldn't stay in business if they were losing too much money on uninsured patients. And that's the logic behind disproportionate share hospital subsidies in Medicare and Medicaid. Because Medicaid is so intrinsically complex, because you have 56 separate jurisdictions, each trying to maximize the amount of money they can get out of the federal government. A number of states particularly took advantage of the requirement that they create DISH programs to come up with really creative rip-offs of the federal treasury. Louisiana was sort of in a class by itself, as you might expect. And New York was really a piker in that regard. And so a whole variety of regulatory limitations and constraints over the years have been put on that. And then, in order to pay for the Affordable Care Act, the argument was made that because there would be fewer uninsured people, there would be less of a need for so-called DISH subsidies, and therefore the federal funding of those programs was cut back in a phased way, presumably as the number of uninsured would decline.
But never implemented.
Okay, questions on this side. Rhonda.
It seems to me there's something very peculiar about the discussion that's taken place, because, you know, to me, the heart of the system is driven by reimbursement rates and what we care to put a margin on and what we care to put a loss on. So you get what you pay for. We get a very, very expensive system that pays for high-tech and very complex procedures, and that pays very little, minus margins, on community health, population health, primary care, and a variety of other things. So everything, almost everything we've talked about this morning is some sort of a fix for that basic, fundamental financial dynamic. We're going to fix it with DSRIP. We're going to fix it with the indigent care pool. We're going to fix it with that. We're going to fix it with a bunch of other things. Oh dear, can we afford to fix it?
Okay, Rhonda, what's the question?
And no one has discussed the basic underlying dynamic. And more than that, the state gave away the authority to determine rates by having privatized, by given to managed care. So I want to understand, am I missing something in this discussion, or did we miss a basic point about how the system works?
That's the question. What's she missing?
Well, the state not only gave away that, they encouraged it because they didn't want to run it themselves because they couldn't. But guess who else gave it away? Obamacare. How is Obamacare run? It's run through insurance companies. So that has been the structure of the nation. How do you change that around? I don't know. I mean, your point is well made about the increment, but what are you going to now do? Say that the most talented surgeon doesn't get anything more for a brain surgery than for a tonsillectomy? Where do you start coming up with your standards? Now, you're the economist, and I know you've changed things around before, so I would welcome a new model.
I'd say look at the margins, look at the fundamental dynamics. Don't look at all the little
All right,
fixes that we've
I'm
tried.
going to jump back across the room to here.
Fred Hyde, I'm another consumer. Mr. Vladeck has referred to what might be called the weaponizing of hospitals to do things for which they are overly expensive and inappropriate. I was astonished at the beginning of the DSRIP thing to talk to the chairman of medicine at Interfaith, and he said to me, Fred, what is it I'm supposed to do? My patients don't have homes, much less home health care. And yet CMS was going to judge the performance of Interfaith on the same basis that we judge the performance of Presbyterian. Is there a role in terms of our social expenditures for some level of government which is not currently taking that role that would take some responsibility for the social cement, which is clearly missing?
You're playing my song, but try to do this succinctly. In part because of the cost of health care, and in part because in pursuit of a larger macro political agenda, we have accompanied as a nation our increased expenditures on Medicaid and Medicare with the drastic reductions in funding for almost every other form of human services. And so when people now say the problem is people don't have housing, they don't have protective services, they don't have early childhood education, they don't have food, that's because we have cut our expenditures on all those other things. If, again, there's famous Commonwealth Fund tables, if you look at healthcare expenditures per se in the United States compared to other OECD countries, we're sort of off the chart. But if you add social service expenditures or human service expenditures, the other, we're right where France is. We just put all our money in the healthcare system and a reduced share, a continuing shrinking share of our money into other human services. The problem, if everyone can agree with that, and not everyone would, but if everyone agreed with that, the problem is, and when people talk about social determinants of health, I say to them, okay, if you're serious of the $3 trillion we're now spending in the healthcare system, let's take $1 trillion and put it in housing for low-income people, in food subsidies, and early childhood education. We know over the next generation that'll do more for healthcare. But how are you going to take $1 trillion when we can't take a nickel out of the existing system it suggests to me we got a real underlying problem that is fundamentally a political problem in addressing the needs of our society.
Okay, we have time for a handful more in the back. You? Go ahead. Yes.
Hi, my name is Dick Park. I'm a benefits and plan sponsor consultant for health insurance. So my question would be, we've kind of lightly grazed on how the system compensates providers, mostly through a CPT code system, right? What about accountable care organizations? So from our side of the fence, we're starting to see the outcome of care as the justification for compensation instead of the frequency of procedure codes that are performed per patient. Do you guys have any comments on the direction of that, and do you think that it could increase private insurance payments towards these hospitals in a more efficient manner?
Value-based benefit. The coming wave, I'm told that private insurance companies now have about a third of their plans and their providers on that. How far that goes, I don't know. I keep on thinking that the limits of ACOs and value-based plans is like woebegone. Is everybody above average? There are ACOs that do a great job of delivering the care, but they don't get any reimbursement because they already were at a high standard. So how do you improve upon the A+ rating? It certainly is a way to go. It does deal with, you're taking it out of the fee-for-service, the reimbursement by procedure, et cetera, and coming to outcomes. And then actually when the next implication is exactly what Bruce Vladeck just said. There's, then you have to go into social determinants.
Did you want to add?
A couple of quick comments on that. One is all the Western European healthcare systems that outperform us on cost and quality almost all of them pay their physicians on fee-for-service. They pay their primary care physicians a lot more relatively to their specialists, to Rhonda's point, than we do. And both of those, I think, are important, but they get better results with it. The second thing is, at the risk of quoting myself, as someone who spent a lot of time as a rate setter and a fair amount of time as a provider, I've been jealous of the advocates of value-based purchasers because I think they have come up with one of the great public relations gimmicks in the history of healthcare. Because what value-based purchasing really is a way that the payers, both public and private, can say to the providers, we're going to pay you less money and make you feel guilty as though it's your fault. And that's what value-based purchasing is all about.
All right, so
Available for consultation.
Some of us have heard Bruce's comments on that.
So unfortunately, as expected, the time has flown by. We're about at the end. So before we get to thank yous, I want to give each of you actually a quick shot, for one closing remark, something that you wish you had said or something you wanted to reiterate. So why don't we start yet again with you, Bill, and we'll just work down real fast.
I'm glad, actually, I had something I wanted to say, and it didn't fit into any of our questions. We've talked a lot about inputs. Money is a big input. In Albany, they talk about, they've gotten into micromanaging wage rates, and they're talking about whether they should set staffing ratios. There's a lot of talk about inputs. I would say we need a whole other component of state government which would be focused on outcomes. One of the big stories that I covered years ago that made a big impression on me was when the state decided to really dig into heart bypass surgery. They gathered just reams of data on every single procedure that was done. They got all the doctors together to figure out the best way to risk adjust it. They published a report, and suddenly hospitals found themselves being held accountable for why their mortality rate was higher than other hospitals. And individual doctors were being measured on their mortality rate. It was a very painful process for a lot of those hospitals and a lot of those doctors, but the moral of the story is that the mortality rate steadily came down over the years. And I thought to myself, wow, this is they didn't change $1 of reimbursement for anybody involved. They didn't close a facility, they didn't open a facility, they just published a report every year, and they got to better quality in a measurable way. There's things about that particular procedure that make it easier to measure. You have a large enough mortality rate that it's relevant to care about. It's not easy to translate that exact process to other procedures. But it's the spirit of that is what I really wish we had more of in state government.
So the power of information transparency. Steve, final thoughts.
My thoughts are, I wish we could figure out a way to actually create a case management system that actually worked and that actually provided consumers with a sense of confidence and knowledge and transparency about their care, and both in terms of quality and cost. But I think we're in a place right now where unless we can figure out how to do that, and so far none of the things I think we're working on is really getting us there. But I think that's got to become the center of change, and I think dramatic change has to take place over the next 15 years.
Thank you. Bruce.
In the category of the opportunity to touch on something that wasn't touched before, I was concerned about the comments about segregation in hospital use in New York, because it's true that there are disparate patterns between the voluntary sector taken as a whole and the public sector. On the other hand, I would argue that hospital utilization patterns in New York are much less segregated than school attendance, than public school attendance, than housing, than library use, than almost any other public service. We have to face the fact as New Yorkers that we've hidden from ourselves, and which has major implications for our health system, that this is one of the most residentially segregated metropolitan areas in the United States, not one of the least, and that has ripple effects all through our community and our culture, and I would argue more seriously in other sectors than in healthcare.
Thank you. We could have so many more additional good panel discussions.
Yeah. I mean,
Elizabeth.
I guess just taking off of that appointment, I also wanted to end on the question of health equity. And I was thinking, gee, I'd be really interested if Bill Hammond wrote a report on how to address disparities in healthcare. And I'm sure we would have an engaging conversation, because I'm not sure your ideas about how to address it would be the same as my ideas, or anybody else on this panel. But I think it is really important for the state to think about how we are not addressing disparities in healthcare, and think about, whether it's financial incentives or other incentives, transparency incentives. I'm not sure. I think it's really an important conversation that our state tried to have a couple of years ago and then just stopped with our we had a very an excellent head of the Office of the Minority Health Council. She left, and since then we just haven't had the important, engaged conversation we need to have. And I feel, in many ways, when we talk about social determinants of health, we're using a different euphemism and not really thinking about racial disparities in health outcomes. And I think we really, really need to address that question more seriously and more straightforwardly.
First of all, I totally agree with Elizabeth. We had initiatives on healthcare disparities. Those were, in a sense, evaporated when we had the recession in 09 and 10. Yep. We did not get back to that. And the New York Times Magazine article about maternal deaths is puzzling, challenging, and means that we have a long way to go. I think it's one of the most important things we can do. I will also just point out one little bit of the foundation that we've managed to build in the last couple of years is going towards electronic medical records that are linked throughout the state, and now going with other states. And second, going to an all-payer database, which obviously has some limits, but we're much further along than we were just a couple of years ago. That's going to be more information that will allow us to make some rational decisions for our health care.